Hello. Um, Good morning, good afternoon, good evening to all you participants. I'm Sanjeev Sabharwal here in California, University of California Children's Hospital. And welcome to our fourth annual UCSF IGOT Pediatric Limb Differences webinar. As you probably know, the theme for today's webinar is on post-traumatic deformities in children and young adults. And we're trying to have a global perspective. And we're thankful to the societies and the departments that have endorsed this webinar, including the UCSF, which is the University of California, San Francisco Department of Orthopedic Surgery, and various professional societies, including the Limb Lengthening and Reconstruction Society of North America, CIGOT, POSNA, Pediatric Orthopedic Society of North America, and POSI, which is the Pediatric Orthopedic Society of India. And as people are joining in, we'd like to know a little bit about you. So we'll be putting up 5 polling questions, and you guys can just click on all of them as it's going on. And Maddie, is it possible to go to the next, or I guess I'm doing it, but I can't advance to the next slide till I end the poll, I guess. Okay. Okay, people are, I can see the screen, and I guess you guys can't see the numbers yet, but once we end the poll, you'll be able to see the numbers. And it's interesting. This is almost like giving a commentary for a cricket match, I guess, that right now Africa and North America are sort of head to head. And then it's Asia, and then Latin America and Europe. No one from Australia yet. But it's building up. And by the way, we have 600 plus registrants. And I'm sure not everybody is going to be able to attend the entire course, but the recording is going to be available. Okay. Maddie, let me know when we want to end the poll. Okay. So, okay. Should I stop sharing?
Yeah.
Do that. Stop sharing and then share results. Okay. Can you guys see the results? All right. So yeah, Africa, at this point, we only have 70 people who are watching, but I know more are going to join in a few minutes. But yeah, it's a good spread. And so that's really what we were trying to do. I'm going to close this poll and then go to the next one. Okay, we shared the results here already. Okay. The next one is, what is your professional background in terms of, are you a medical student? Are you a postgraduate trainee? Be it, a postgraduate like a resident, a house surgeon, etc. Have you been in practice for less than 5 years, more than 5 years, or are you an allied health professional or something else? Mary, can we run that poll, please? Not sure if that's running for you. I can't see it. Oh, okay. This we are done with. This is the first one. Where are you from? Oh, I see. It's below that. Okay, got it. It's probably me. Okay, here we go. Okay, so in terms of who our audience is, I would say 47% are practicing surgeons. Then we have a lot of trainees, a few practicing surgeons with less than 5 years experience, and some allied health and other professionals. I'll just run through the questions and then we'll share the results all together. The third question was, how would you describe your experience treating post-traumatic limb deformities in children and young adults? And I think a 70% answered somewhat experience, which is great, which is, sort of what we want. Of course, there were some with minimal experience, and 4% said very experienced. So that's awesome too. And, during panel discussion, we can take advantage of all of that good experience. The fourth polling question was, what percentage of your practice is performed in austere environments, meaning with limited resources? And 46% said less than 25%. And interestingly, 25% said more than 75%. So again, I love the mix of different experiences when working in environments with limited resources, as well as those with a lot of resources, because that's kind of the theme of this webinar. And then the final question was, in your experience, what is the most common cause of post-traumatic deformities in children in your practice? And 48% answered malunited fractures with inadequate initial care. And then the second most common was sequelae of physeal injuries. So I'm going to share the results, and hopefully you guys can see that. And you might have to scroll up and down to look at all 5 polling questions. So I'll just leave it up there for a few seconds. And then I'll say stop sharing. Okay, I think we've already done that. So I'm going to close this and then move on. Okay, so the program today, it's a half-day webinar. The target audience is really all learners across the globe, not just orthopedic surgeons and trainees, but like we've seen in the audience poll, it's really relevant to a very broad audience. So there'll be 4 sessions that are divided thematically into one of the themes on post-traumatic deformities, starting with sequelae of physeal injuries, then malunions, then non-unions and bone loss. And this year we've tried sort of a new theme, which in Indian colloquial parlance is called jugaad. And we'll touch on that briefly in the next few slides. But that's got to do with innovative techniques and frugal innovations in limited resource environments. So each of these 4 sessions is going to have a 10-minute intro talk from one of our panelists, and then really sort of rapid-fire 4-minute case presentations by multiple faculty, and then a rich panel discussion for about 20 to 25 minutes. And during that panel discussion, I think I would encourage the participants to put in their questions. And this is how you would ask a question. So on your screens, I think towards the bottom of your screen, there are these different Zoom buttons. What you cannot use is the ones on the left, which is you cannot chat or raise a hand, unfortunately, for this webinar, but you could definitely ask questions and our panelists will answer them either directly online or we'll bring it up during the panel discussion for a broader audience. So that's really how we're going to interact during this webinar. So here, I would encourage all our faculty, if you can just switch your cameras on for a second. We're really lucky to have a very broad audience and panelists from all parts of the globe. And, these are all experts in their field, and we're really lucky to have them all in one webinar. So thank you, everybody. And of course, we've got our host team who've done all the heavy lifting for the course. So thank you. And we'll give a more detailed intro before each of their talks as we go on. Finally, I'd really like to thank our core team that has supported this webinar and couldn't have done it without their help. Firstly is Dr. Maddie McKechnie, who's the Director of Global Programs for the Institute of Global Orthopedics and Traumatology, that is IGOT, here at UCSF, Bridget, who's our academic assistant in pediatric orthopedics, William Shirley, who does the audio visuals and has done a lot of work with collating the slides. And of course, a lot of team members, including Michelle Capello, who's the service line director, Ryan, who was our clinic manager, Alex Giraldi, our physician assistant, Derek Moore, who's a surgeon with Ortho Bullets. And we partnered with Ortho Bullets this year, and that's been a great experience for us. And finally, the IGOT team, and last but not the least, all our staff at the UCSF Benioff Children's Hospitals, both sides of the Bay, Oakland and Mission Bay, and of course, our dear patients and their caretakers, their families, who've in some way contributed to this webinar. So just as an intro, we all know there's a north-south divide in so many different ways across the globe, be it economic, resources, et cetera, et cetera. And sometimes you don't even have to cross countries. Even in the same neighborhood, you will see a well-resourced and a less well-resourced environment. And that's true in terms of access to surgical care as well. And interestingly, the population, of course, is growing globally, but at a very differential rate. A lot of low middle-income countries, the population is younger, whereas in the high-income countries, they're much older. And if you look at this one sobering statistic, road traffic fatalities in under 19-year-olds, 95% of those fatalities happen in low middle-income countries, including sub-Saharan Africa and parts of the Southeast Asia. So I feel like it's very relevant to bring things together. And the old model for teaching and training, I don't think is relevant anymore since, people are getting more versatile with different learning platforms, et cetera. And certainly high-income country surgeons, I don't think, have the full vantage of what's available and what the real issues sometimes are in resource-limited environments. So I feel like the goal here is to try to get the crosstalk going, get bidirectional learning going, and learn from each other's experience. And I mean it in the truest sense of the word, that we can all learn from each other. And then finally, this, as I mentioned earlier, Jugaad is an interesting concept which brings together frugality, flexibility, and inclusiveness. And that sweet spot where you can get a little bit of all three is what's termed Jugaad. And it's like a out-of-the-box thinking, and I feel it's very pertinent in our field as well. And so, there are a lot of frugal innovations that are out there in orthopedics as well. Here's just a few examples, and, some of these faculty are actually part of this webinar, so we're lucky to have them. So without further ado, let's get started. So we're a minute or two ahead, which is great. So as I mentioned, we're going to have, 4 sessions. The first session is on the sequelae of physeal injuries. And the intro talk is going to be given by my dear friend, Mark Eidelman, who's from Israel. He's a associate professor at Rappaport Faculty of Medicine in Haifa. He's been the director for pediatric orthopedics for a number of years at the Ruth Children's Hospital and is the past president of the Israeli Pediatric Orthopedic Society. So I'm going to try stop sharing, and I will let Mark and our faculty drive this.
Can I start, Sanjeev?
Yeah, actually, you know what? I'd never start sharing. So you've got it, right, Maddie? You have the...
Yes.
Okay, awesome.
Okay. Thank you for having me. Thank you for the invitation, Sanjeev. It's a really honor to be with you. I will try to share with you what I know about post-traumatic growth plate injuries. Can you hear me?
Yes. Yes.
Okay. So, next, please. This is my hospital, Rambam Hospital of the Haifa, and I hope that in a more peaceful day, many of you will be here. Next, please. So, shortly about etiology, most of the post-traumatic physeal injury comes from fracture, of course, but it also from ischemia, compression, repetitive stress, rarely thermal injuries. All these conditions can cause growth arrest. Next, please. So, shortly about anatomy of the physis. Zone 1 is a resting zone, relatively inactive. Zone 2 is proliferation. Zone 3 divided to 3 zones. Hypertrophy, zone of the hypertrophy, it's subdivided to maturation, degeneration, and provisional calcification. Penetration of provisional classification lead to growth arrest. Next. Next, please. So, is this zone? I wonder that Holland described his classification exactly like Salter-Harris, 3 types, 1, 2, and 3, without Röntgen in 1998. Next, please. So, I can add that his type 3 is actually Salter-Harris type 4. Next. And these 2 gentlemen, 2 robbers from Toronto, Salter and Harris, just adopted the Poland and Aiken classification. Next. And they added type 5, which is epiphyseal compression. Next. So this is the histologically how the Salter-Harris looks like. Next. And we start with Salter-Harris type 1. This is transphyseal plane injury. On the plane X-rays, not always you can see what happened. So ultrasound or MRI will help. I will never do stress X-rays, and there is an injury or a hypertrophic zone. This type is rarely cause a growth arrest. Next, please. So Salter-Harris next. It's not penetrated proliferative zone. Salter-Harris type 2 is involve physeal and metaphyseal components. There is the famous Thurston Holland triangular fragment. This type is most common, but it's also, fortunately, not cause the growth arrest. Next. Next, please. As you see, there is no penetration of proliferative zone. What should we do if kids come, let's say, after 7-10 days and not adequately reduced? Dennis Wenger, in his Young Children Fracture book, state that they should left untreated, uncorrected, because of the risk for damaging of growth late. You can always later, if it's not remodeled, to perform osteotomy. Next, please. So Salter-Harris type 3 have a great potential for growth arrest because the fracture penetrate germinal and proliferative zone, and anatomic reduction in this type is crucially important. Next, please. Yes, this is the histological, and you can see the fracture across the proliferative zone. Next, please. So Salter-Harris type 4, you should tell, if you see this fracture, you should tell the parents that most probably growth arrest inevitable. And it leads to metaphyseal, epiphyseal cross union because it violates all physeal layers. Let's take next example. Yes, as you see, histologically. Next example, please. So, not dramatic displacement, Salter-Harris type 4. And someone did closed reduction and percutaneous fixation with the screw. Look how it looks like after 6 weeks. Yes, there's a slight step off, as you see. But look, even after 6 weeks, so early, you can see that the growth arrest is already there. And you can see the step off, next please, and some small gap. And not surprisingly, yeah, this is the gaps. Next please. Next. Yes. And not surprisingly, after 2 years, we have these x-rays. And after 3 years, it's a real catastrophe. Next year, next, please. Looks how it looks like after 3 years. That's why anatomic reduction is crucial and follow-up crucially important in type 3 and 4. Next, please. Salter-Harris type 5 is compression injury. Initial x-rays nearly always normal, and it lead to complete growth arrest. Next, please. So Peterson added that his type 1 is actually T fracture. It's very common in distal radius, like in this photo. And 6 is just loss of part of the epiphysis. Next, please. A physeal breach may begin as early as 1 or 2 months. You already saw this, but may not be apparent for until years. Next, please. So, growth arrest more common in upper extremity, surprisingly, but in lower extremity, distal femoral fracture next is, despite that it's uncommon, that there is high prevalence of subsequent growth arrest. It's number 1 in lower extremity. Next, please. The second common is a growth arrest of the distal tibia, like in this excerpt. Next, please. So what are treatment option for growth arrest? First, we have physeal bar resection. This is most reconstructible option, but it's dependent on the location and dependent on the magnitude of the growth arrest. In this example, there are 55% of involvement of the physis. Probably physeal bar resection is impossible to perform. The next option is completion of physiodesis. Third is chondrodiastasis, very painful, by the way. I did it several times. And lip lengthening and deformity correction. Next, please. So what is important? The most important factor if growth arrest happened is the age. The second one is projected leg length discrepancy at maturity. Next, please. So clinically, it, as I said, may not be apparent for many years. Angulation shortening may take time. Joint orientation in coronal and sagittal planes is important. Always look on the x-rays, long x-rays and angular assessment, and follow-up is crucially important. Look on these x-rays. You see the early signs, Harris line oblique to proximal tibia epiphysis. It's early signs of partial growth arrest. Next, please. So what is the best imaging for detection of growth arrest? MRI is ideal. The second best is CT, but it might miss the bar when it's small or perpendicular to the plane of the CT. Next, please. What is most important, in my opinion, is it partial or complete growth arrest? Next, please. So this is the nice example of partial growth arrest that coming with progressive deformity and shortening of affected limb. If you see such deformity, it's always a partial growth arrest. Next, please. With complete growth arrest, and there are less worries. All what you need is to equalize leg length discrepancy, and for decision making, age is most important factor. Thank you. Next, please. So we have to know what is the predicted height, the decision making. If the child will be 150 centimeter or 155 is different. Parent willness, lengthening versus contralateral physiodesis is always an option. Next, please. Next, please. So, regarding partial growth arrest, observation is a wrong option. Bar excision, and there's complete closure of the epiphysis. What is on the menu? Next, please. So when we are doing completion of epiphyseolysis, percutaneous drilling, most effective and minimally invasive option. Next, please. This is important, in patient less than 11 years old, it must include closure of the proximal fibula, beware of the peroneal nerve. That's why there is no percutaneous technique on the fibular side. You can do percutaneous. I always doing percutaneously on the tibial side, but not on the fibular side. Next, please. And epiphyseolysis of the distal tibia is easier and safe from medial to lateral. It must include fibular closure. Beware of the medial posterior aspect because of the closure of the neurovascular bundle. Next, please. Let's take this example. A partial growth arrest of distal tibia, 9-year-old girl with 7 centimeter. Next, please. With 7 centimeter leg length discrepancy, 10 centimeter projected leg length discrepancy. At the time when I did this case, there was no internal lengthening. But first step should be epiphyseolysis of distal femur. Next, please. Next, please. So this is the epiphyseolysis. Next. Next. It might be done percutaneously, very easy to perform, and after this you have time to decide what is the next treatment step. So, as I said, there was no internal lengthening. I did deformity correction and 5 centimeter lengthening at the first step. Next. And this is an additional 5 centimeter of lengthening, and this is the final alignment. Next. And that's how she looks at skeletal maturity 9 years after. Next. We are living now in the real revolution, in the era of internal lengthening. We are so lucky there is no transfixion of soft tissue, less pain, less infection, quicker motion regain. Next, please. Here's an example. 14-year-old with post-traumatic malunion and 4 centimeter shortening. Next, please. We can do fixator-assisted acute correction, nailing, and deformity correction and lengthening. Next, please. Next, please. And it's amazing. This is only after 2 months after nailing. Partial growth arrest of the proximal tibia. Remember, in patient more than 2-year-old, remaining growth of proximal fibula should be closed. Completion of growth arrest is the simplest, cheapest, and most predictable option. Next, please. So this is an example of 7-year-old girl with partial growth arrest medially and anteriorly. So if you perform epiphyseolysis, it should be done in both planes. Next, please. Exactly like here, mediolateral and anterior to posterior. Next. So I did here preemptive lengthening, deformity correction, anatomically in both planes. Next, please. But it's very difficult to estimate how much exactly you should do lengthening. So we started treatment when she was 7. Next, please. At age 10, she pretty equal, but there is remaining growth of the proximal tibia. On the right side, I decided that I will do contralateral epiphyseolysis. Next, please. Next, please. At age 12, she has she have exactly the same length on both sides. Next, please. So when you have significant shortening of the tibia and double level deformity. Next, please. Like in this case, there is a mythos that in kids everything will be fine. But look at this 19-year-old soldier. When he was 5 years old, he had physeal fracture, now has 6 centimeter leg length discrepancy. In such case, you have to perform a correction of deformity distal, minimal lengthening, and remaining lengthening from the proximal tibia. Next, please. So this is the deformity distal. Next, please. Yes, next. And remaining lengthening we did from the proximal tibia osteotomy. Next. This is his final alignment. Next, please. Gross arrest of the proximal tibia is very common. You can easily treat this condition with hexapods. Next, please. Next, please. This is the final alignment. Next. Next, please. Not everything we know. Not everything we know. And this is what I call victim of urban violence, 11-year-old boy with gunshot, what I call Salter Harris 7100. Next, please. Look at the proximal tibia. Next, please. It's not described type in Salter Harris classification. Next, please. So, in conclusion, next, the observation is a wrong treatment option in partial gross arrest. Frequent follow-up needed to exclude damage of the physis. In older children, epiphyseolysis is most predictable option. And what is most important, take-home message, worry a lot. Thank you very much.
Thanks so much, Mark. That was really great. And, because of time constraints, we're going to do a combined discussion during panel discussion session. So for the audience, please write down your questions in the Q&A section. And we're going to move on to these next few talks, which are meant to be 4-minute talks on different cases. And our first speaker is Christoph Radler. He's from Austria. Vienna, University of Vienna. He's the associate professor of orthopedics and a senior consultant and head of the pediatric orthopedic unit there. And he also heads the Clubfoot Clinic in Vienna. And Christoph's going to talk about physeal bar resection and a case along those lines. So take it away, Christoph. Thank you.
Thank you very much. Thank you for the invitation. It's a pleasure to be here. Let me start right away. This was a patient who had a fracture of the proximal tibia playing soccer. He had a K-wire fixation of this fracture. The K-wires were left in place for 2 months. I saw him 7 months after the trauma. He had some pain and he had some varus malalignment and knee hyperextension. When I looked at the x-rays, I suspected physeal bar, so I did a CT. Maybe we go back again. I did a CT, and on the CT you can see there is a small bridge, a physeal bar, and it's quite anterior and medial, more anterior. Next, please. And so one thing is you need to, so I decided to resect it. It can be difficult to localize the bar. You want to kind of map it out for you to see where you're going to do your resection. And of course, you can also visually make sure that you resect enough and that you see the physis. I did an interposition of gluteal fat that can be taken very easily from the gluteal skin fold. And you can always get enough fat there, so even in very, very slender people. And that seems to work very nicely. So next, please. This is 4 weeks after the bar resection. It looked fine. 6 months later, it seemed fine regarding growth, but there was still a varus deformity. And because there was a recovatum and varus, I decided to use a guided growth using a screw, which I usually don't. But in this case, it allowed me to place the hinge point in the posterior lateral physis. And next, please. This seemed to work very nicely. It corrected the varus alignment and partially also corrected the requavatum. Nevertheless, the frontal plane correction was faster than the sagittal plane. So as you can see, at the time in the labral straight, it was still in requavatum. So I added a second screw to continue correcting the requavatum. Next. And here you can see then in the lateral view how the requavatum really fully corrected. Also, the alignment in the AP plane stayed the same. Next. And this was like the result before screw removal and at the age of 15 with a nice PPTA and a good alignment. Next. I just want to show you a very quick variation of the above. Next. This pretty much the same case, like 11 years, 9 months after trauma, requavatum, valgus, pain. But now if you look at the bridge, it's much more posterior. It is significantly more posterior, which made me decide to do the resection, not direct, but indirect. Next. You can see here, this is the CT after this, the resection. It looks pretty big, but you need to make sure that you get all this. And of course, one way, if you want to visualize it, you can use the arthroscope to look inside. Next. And from there on, you can see that the requavatum, which was less in this case, remodeled quite nicely. The valgus was still there, so I did a classic plate and screw kind of guided growth to correct it. Next. So take-home message, I think the CT with an exact mapping of the bar formation to locate the bar works very nicely. You can do a direct or the indirect resection. The gluteal fat pad is sufficient to prevent the recurrence of the bridge and is easily harvested and just resolves by itself. And I prefer to do the guided growth secondary to correct the alignment, and that's maybe something we can discuss. Thank you.
Great. Thank you, Krista. That was great. It's going to bring up a lot of questions. Our next speaker is my friend Rick Gardner. He's a pediatric orthopedic surgeon at Sick Kids in Toronto. And prior to that, he worked for the Cure Hospital, mainly in Eastern Africa. He's been the chief medical officer for Cure International in Ethiopia and Zimbabwe, and has tons of experience working in both environments. He's also the lead examiner for the pediatric orthopedic section of COSEXA, which is the College of Surgeons in Eastern, Central, and Southern Africa. And Rick's going to build on this theme with a case on epiphyseolysis and guided growth. Thanks, Rick.
Sanjeev, thank you. Thank you. It's wonderful to be with you all. Very grateful for this opportunity. Next slide, please. So as Sanjeev's saying, this is really building on for what Mark and Christoph have been talking about. This is a 3-year-old girl from Ethiopia who had an injury some 6 to 12 months previously, and had developed a progressive varus deformity of her left leg, with a 2 centimeter leg length discrepancy. Radiographs were suggestive of a little physeal bar on the medial aspect of her physis, not a peripheral bar, but just on the kind of the medial third of the physis that you can see on the knee film, and then a varus deformity. Of course, this angle is switched around, but some 20 degrees of varus alongside the 2 centimeter leg length discrepancy. Next slide, please. So the management options, we discussed some. So an osteotomy is appealing, can give immediate correction. It won't necessarily help with the leg discrepancy, but an opening wedge would certainly help with that, with the inevitability of recurrence, in the same way that Mark was saying, that a partial growth arrest is something which will be an ongoing driver, particularly in such a young girl. Guided growth, you can put a lateral A plate on, but that would likely just hold the deformity and not make it get worse. And eventually that A plate tends to break. The physis is remarkably strong and will overcome A plate fixation if there is a tether. Epiphyseolysis, of course, could be a great option, but then will that actually result in full correction? Possibly. Next slide, please. But it's a combination of the two, which is particularly attractive. And Christoph was alluding to this, and with some great examples, the last two cases which he used this. And that combination of an epiphyseolysis, a physeal bar resection alongside guided growth in cases like this, particularly in such a young child with so much growth to go, can be a very attractive option. Next slide, please. So the CT scan, the quality of the CT scan is enough to suggest that where the physeal resection, physeal bar is. And you can see this is a particularly nice one. It's a small little spot weld on that medial third of the physis, and possibly slightly anterior as well when you're seeing on that lateral view. And that mapping, as Christopher's Mark is saying, is very helpful just to help you get it in the right place. Next slide, please. It's particularly appealing when you can actually see it under C-arm. And so you can see that little tether there. There are some comments in the chat saying, how do you kind of ensure that you're getting a complete resection? If you can see it under C-arm, you just feel a lot happier in the OR. And this is a DHS guide wire through a lateral window heading to the medial aspect of the distal femur. Far easier coming from the contralateral side because you can get the right trajectory. Coming from the lateral side, it's very hard to get that trajectory because you're the wires running up the femur, but from the lateral side, much easier to go medially. And that guide wire hitting the center of the physeal bar resection. Next slide, please. And then going quite big. I mean, it seems enormous, but actually it's so helpful to have a big resection for various reasons. One is you're more likely to clear it. This is a DHS reamer, which does feel large for a 3-year-old, but enables you to get a good clearance around the area. You can then get a burr in, and you've got room for that. And then there was comments in the chat saying, what about guaranteeing your resection? And an arthroscope is helpful. You don't, of course, put fluid in, but you can pass an arthroscope down and they get a circumferential view and see if you can see that line of the physis circumferentially. And if you see it in 2/3 of it, just keep going with the burr and burr a little bit more out until you can see that. And that's the best chance you have of having the outcome you wish for. And then putting in buttock fat in exactly the same way as Christoph was saying. If you've got cranioplasty, people have recommended that because it doesn't heat up the same way as bone cement. But we tend to use buttock fat, and bone wax is also helpful. And then putting on a lateral 8-plate. Next slide, please. And then it's kind of magic the way that sometimes this works. No, it doesn't always work. And of course, we're showing you the ones where it does work, but we can also show you ones where it hasn't worked. But this was a particularly attractive one, being a small spot weld. You can see the 8-plate screws are spreading, suggesting medial growth. And then just when you get over correction, 8-plate out. And there was even some correction of the leg length discrepancy as well, which was an extra bonus. Next slide, please. So CT to map out the bar, large drill, and then a burr. The arthroscope can be very helpful for those, often coming from the contralateral side for these more peripheral ones, and supplement with temporary hemiepiphyseolysis. Thank you very much.
Great. Thanks so much, Rick. Really a lot of info there. So next is Sandeep Patwardhan. Sandeep's from India. He's a professor of orthopedics at Sancheti Institute for Orthopedics and Rehab in Pune, India. He's the honorary visiting pediatric orthopedic at the Bharati Vidyapith Hospital locally, and is also on the executive board and the past secretary of the Pediatric Orthopedic Society of India. And Sandeep's going to talk about osteotomy with epiphyseolysis. So please go ahead, Sandeep.
Thanks. Thank you. Thank you, Sanjeev, for this opportunity. And I'm going to present a case of a very young child who had a growth arrest after a conservative treatment, plaster treatment, for a distal tibia. So this was apparently treated as a Salter 2 injury to the distal tibia. 2-year-old girl, very young, and was put in a cast. Next. And a year later, the parents noticed that though she was walking quite well, she was developing a progressive deformity around the ankle, which made her walk on the outside of her heel. And if you can see that there was a tilting of the distal tibial slope, the fibula was overgrowing, and the obliques also showed that probably in the center there was something happening, probably a scar there, a physeal arrest, and that was changing the shape of her distal tibia as well as causing deformation. Next, please. So we got an MRI and a CT done, and we found that there was indeed a physeal arrest bar. And as Mark and Christoph have already said, the younger the child, if I cannot afford to leave it like this or just observe. And as Rick said, these children may also need multiple procedures in the future because you always cannot guarantee them a very good result. But leaving them alone and waiting on them does not really help, because you can see that there is progressive deformation, as well as the child has a long way to go. There's a lot of growth left there. So what we decided was that we should approach this by doing an osteotomy for acute correction, and through the same approach, if we can get that physeal bar resected and use an interposition, the inert fat which has been coated, that is what we decided to use. Next slide, please. So this was a clinical deformity. Next slide. This is a very old case, 2001 or so. And so what I did was we did a metaphyseal osteotomy and approached through the osteotomy into the center of the tibia where the bar was located. And we did an angulation translation correction. I osteotomized the fibula and used a mini external fixator because we did not have an adequate implant for such a young child. I just used a locally made BB Joshi's fixator with small mini clamps. And after burring the physeal bar, we put some fat there in the center, confirmed it on C-arm, and then we put a small mini external fixator. Next, please. And that is how it looked at the end of the procedure. So monolateral, simple mini external fixator. And I gave her an additional below knee plaster slab support and waited on her for about 6 weeks. Next, please. So this is a 5-year follow-up of this girl. And we found that after the bar resection, the peripheral part of the tibia continued to grow quite nicely. The osteotomy healed well. She maintained the correction quite nicely and continued to grow very well. Now this, as Rick has said, we are just showing you the good results. This may not work each and every time. But the pointers are that you need to do a large resection. Don't under-resect the physeal bar. It's okay to over-resect. And put something which will allow further growth like fat and does not burn bridges, and also monitor them for long enough. So this was a 5-year follow-up and I was pleasantly surprised. Can you show the next slide, please? That as she grew older, this was her alignment. Next slide, please. And that was her function, and she was running, hopping and doing almost everything without any symptoms. This was really a long time ago. Next slide. And this is a 13-year follow-up of the same kid. She's now about 15 or 16 years old, doing her 12th classes. And this is the alignment which has been maintained over the years, and she ended up without any limb length discrepancy. So it is like a stitch in time, really saved 9. So if you are seeing a very young child with a localized physeal arrest, deformity correction with resection of the physeal bar and long-term observation is a very good option, and this child did do well, though we counseled the family that in case there is recurrence, we may have to go in again and redo some procedure in the future. Next slide, please. So bar resection should be considered for localized bars less than about 30 to 40%. Fat interposition works well to prevent reformation. And acute correction with excision maximizes the growth restoration by equalizing the forces on the physis. And you need to keep a long follow-up to recognize further growth disturbances. So thank you very much for your attention.
Thanks, Sandeep. And, just a reminder to all our panelists that there are a lot of questions from the audience in the Q&A section. So anyone can respond. So it'll be a nice live discussion on the side. So please respond to the Q&A questions from the audience. Next is my pleasure to introduce Emeka Izuagba. He's from Lagos, Nigeria. He's a senior consultant at the National Orthopedic Hospital there and has a special interest and expertise in complex limb reconstruction and is the founding member of the Limb Lengthening and Reconstruction Society of Nigeria. And Emeka is going to talk about physeal injury stage reconstruction. Thank you, Emeka.
Yeah, thank you, Sanjeev. Thank you, everyone, for having me. So I'm going to present two patients that presented years after they suffered the physeal damage to their distal tibia. Next. So above is an 11-year-old patient that presented with a left ankle valgus deformity. This followed an open ankle injury that was sustained at age 6 years. So it was presenting 5 years after. Initially had traditional treatment, which worsened his deformity. On presentation, we discovered that he had a lateral tibial and fibular physeal arrest as displayed on the images and then the X-ray views. He also has a right genovarum which developed compensatorily due to the limb length inequality that arose. So the plan we had for him was to address the ankle valgus first and then the genovarum after. Next. Next, please. So what we did was an accurate correction. We took a large medial-based triangular wedge of bone out of the distal tibia and fixed it with a distal tibia plate and screw. He had a very good outcome. He was able to walk for the first time in a long time on the sole of his foot, plantigrade foot. But unfortunately, we've not seen him since 3 years after the treatment. Most of them, they don't have problems, they don't usually come. So the similar case is that of the above patient. It's actually a 16-year-old patient, second of identical twin, who suffered a traumatic open soft tissue injury in infancy. At that time, she was taken to a traditional bone setter as well, and then presented a year after to our hospital, where she was planned to undergo soft tissue release and ankle fusion, but the parents declined and then left afterwards. Then presenting later at 12 years after, when she was 16 years, she presented with a gross deformity that worsened over time with a significant limb length inequality associated with the deformity. At this time, she had a limb length inequality of 12 centimeters. Next. So the problems we had were a very gross deformity, 180 degrees of deformity with severe soft tissue scarring and contracture. The poor soft tissue support in the distal tibia. The plastic surgeons couldn't do much about the poor soft tissue that was in the ankle, which could have helped us in reconstruction. And the patient was offered amputation and prosthetic fitting, but they strongly declined. So the treatment we chose was correcting that deformity acutely, the deformity in the ankle acutely. And then for the limb length inequality, we'll plan to lengthen at the same sitting. Next. So that was what the treatment he had. We applied a ring fixator, corrected the distal tibia and deformity acutely. During the treatment, during the acute correction, he had a lot of soft tissue defects, which was addressed right there in the theater with skin grafting. And fortunately, everything went fine. He had an uneventful lengthening. The problem he had is that they stay in a neighboring country west of Nigeria, so follow-up was pretty difficult. But we managed to get her to the treatment to completion. And at the end of the day, we equalized the limb and were able to achieve a plantigrade foot that was able to be placed on the floor. Next. So this was the outcome of the treatment. He had a little ulcer on the medial aspect, which was addressed as on a day case basis as skin grafting, but she was able to walk without any problem. Next. So that was the final outcome. She also hasn't come to the clinic for 18 months. I've been trying to reach them, but apparently they are better. And when they don't have any reason to come, they usually don't come to the clinic. Thank you very much for listening.
Thanks, Emeka. And we're going to move on. Next is my partner in practice, Dr. Jackie Hill. Jackie is an associate professor in the Department of Orthopedics here at UCSF, and she's a senior leader in Limb Lengthening and Reconstruction Center here at UCSF, and is also part of the executive board at the Limb Lengthening Reconstruction Society of North America. And Jackie's going to talk about deformity correction with intramedullary lengthening nail. Jackie, welcome.
Thank you. Thanks for asking me to present and participate. So I'm going to talk today about a distal femoral physeal injury. Next slide. So a 7-year-old presented with a displaced Salter-Harris 2 distal femur fracture after an injury. He was initially fixed with closure reduction, percutaneous pinning. Next slide. These are his x-rays at 6 months post-op. He's already developing a physeal bar apparent. Next slide. And a full-length scanogram shows that he's in significant valgus and he already has a 3-centimeter leg length discrepancy. So what are the options here? So the options are to attempt a bar resection, as has been discussed previously, to combine this with some guided growth if you think it's going to be successful, or to do a completion of his bar, so a completion of epiphyseolysis, and perform an acute correction with an osteotomy. Next slide. So given his amount of deformity, I thought that a bar resection would be unsuccessful. So the family and I elected to perform a completion of epiphyseolysis, and then we did an acute correction with an external fixator-assisted distal femoral osteotomy. So this is a trauma nail showing his improved alignment. Next slide. His ultimate leg length discrepancy was predicted to be 9 centimeters. So we exchanged his trauma nail for an internal lengthening nail, and the family elected to over lengthen him with one lengthening setting. So he got lengthened 8 centimeters. And he's now nearing skeletal maturity, and his leg lengths are relatively equal. Next slide. So in conclusion, one treatment approach for a partial physeal rest that's not amenable to bar resection is a stepwise treatment plan, starting with a completion of epiphyseolysis with deformity correction. In this case, I used a fixator-assisted intramedullary nailing. And then step 2 is to exchange the trauma nail to an internal lengthening nail to address the leg length discrepancy. Thank you.
Awesome. Thanks, Jackie. And last in this list of quick cases is my dear friend Chris Jobst. Chris is going to talk about, he's the director of Center for Limb Lengthening and Reconstruction at Nationwide Children's Hospital in Columbus, Ohio. He's the current president of the Limb Lengthening and Reconstruction Society of North America. And he's been a real champion in the theme of physician burnout prevention, which is actually going to be a theme at the upcoming LLRS pre-meeting. And Chris is going to talk about deformity correction with extramedullary and intramedullary lengthening nail. So thanks, Chris.
Thanks, Sanjeev. Great to see you. You can go to the next slide, please. So I'm presenting a case of a 4-year-old boy who had a lawnmower injury primarily to his left distal femur, patella, and the overlying soft tissues. Next. These are the initial postoperative radiographs from the outside institution showing the initial orthopedic fixation of his injuries. Next. Radiographs 3 months after the injury show interval hardware removal with early signs of physeal arrest developing the lateral distal femur. There's also some relative bone loss to the lateral femoral condyle, creating a hypoplastic condylar situation. Next. Here's the standing radiograph at about 5 months after his injury, showing the overall valgus alignment that is occurring from the combination of his physeal injury and the loss of lateral femoral condylar height. Next. 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 So these are intraoperative images, again, from the outside institution where the decision was made, and I think rightfully so, to complete the distal femoral physis epiphyseolysis to prevent worsening of the valgus deformity. I like that they went at it from both sides and not just one side. It can be hard to get good destruction of the undulating distal femoral physis if you only try to reach it from one entry site. Next. So this is where I met the patient. He's now age 6 with this valgus and a known distal femoral growth arrest from injury and iatrogenically from the epiphyseolysis. Next. Here are the overlying soft tissues with evidence of the skin grafting and skin graft donor sites that were done to correct his injury. Next. So when deciding management options for the valgus and leg length discrepancy, which we know is going to be increasing about 1 centimeter per year over the next 10 years, external fixation at this point is the expected choice. However, given the soft tissue damage that I just showed you, I was not thrilled about the prospect of putting pins through that area and having them drag through the tissue with the lengthening. The family actually came to us because we could offer them something different. We chose to use an internal lengthening nail, but in an extramedullary fashion. Next. So because the child is too small for the nail to go inside the bone, we simply slide it along the lateral surface underneath the tissue. We then performed an acute correction of the distal femoral valgus using a medial half pan as a joystick to hold the desired position before fixing it in place with interlocking screws. Next. Here's clinical photographs in the OR table of the valgus deformity before the case on the left, and then after the acute correction with the internal extramedullary nail on the right. Next. We use the internal nail to achieve approximately 4 centimeters of lengthening. You can see that the alignment was maintained in both views without deformation of the regenerate bone. Next. Follow-up radiographs demonstrate full correction of the limb length discrepancy and improved alignment. This is both before and after hardware removal. Next. 4 years later, now at age 10, the patient returns with a recurrent limb length discrepancy and valgus deformity. The valgus indicates that the epiphyseolysis may not have been completely successful. Next. At this point, our options run the full gamut from observation to intervention. The child is an avid athlete and the family would like to correct his leg lengths and the valgus again because it's affecting his performance. They do not want anything done to the good leg. We are still going to avoid the femoral fixator option, so we have to decide how to utilize an internal lengthening nail. It could be used as an extramedullary nail again, or because his femur is now bigger, we could insert it in a retrograde manner since his distal femoral physis is already closed. Next. So using rigid reamers and blocking screws, we acutely corrected the valgus again, and then inserted a retrograde intramedullary lengthening nail. Next. Post-op radiographs demonstrated slight over-lengthening of more than 4.5 centimeters since we knew that he was going to continue to fall behind again in the future. Next. Post-op radiographs showing excellent consolidation of his regenerate and maintenance of his alignment. Next. And these are his final radiographs after removal of the nail. The plan is to perform a final lengthening at skeletal maturity with another retrograde internal lengthening nail. Next slide. So the take-home messages are, number 1, an epiphyseolysis may seem like a straightforward, benign procedure, but you definitely need to continue to follow your patients until skeletal maturity. Sometimes the worst result is a partial success. Number 2, in our center, we have a real disdain for external fixators on the femur. We try everything in our power to avoid using them. Extramedullary lengthening is a nice alternative in the right circumstances. Number 3, however, if the nail can fit inside the bone safely, that is always the primary choice. With the distal femoral physeal injury, we had the opportunity to use this nail as its intended intramedullary location in a young patient that I would otherwise never have considered using it. And finally, as experience grows and time passes, more and more patients are having sequential lengthening of the femur with internal lengthening nails, just like this patient. It seems that they do well and they can make healthy regenerate bone the second time and potentially even a third time. Thank you.
Thank you so much, Chris. That was awesome. Really, kudos to all the speakers. That's, and you pretty much stayed on time, and what a nice spectrum of cases. Unfortunately, we have, limited time for discussion, but we still have a good 15 minutes. So let's just start with a polling question. And this is just to kind of get a temperature on what is your biggest challenge in terms of treating children with physeal injury-related deformities. And we've got a lot of good question answers going in the, on the chat as well. And that is awesome. And we're going to, supplement that with a case of mine, which actually didn't go as well. And so, hopefully there'll be some learning there. And I feel some of the themes that have come up during these case presentations, and if any of the panelists can touch on it during our case discussion, would be one, the technique for epiphyseolysis, one incision versus two, pros and cons. How do you assess a physeal bar? What are the different indications for physeal bar resection, etc.? And then one other thing, which we may or may not cover in this section, but we'll certainly cover in one of the later discussions, is what is the alternative to internal magnetic lengthening nails in environments and countries where that implant's not available. So, okay. So this is our, can the people see the responses, or I got to stop sharing, right, Maddie? I got to stop sharing?
No, they can see them.
Okay, awesome. So as you can see, what is your biggest challenge? A third of you said timing and planning for surgical intervention. Absolutely. As well as followed by early and accurate diagnosis.
Morning. Happy graduation. Thank you.
And then long-term follow-up and compliance. Okay. So let's stop sharing and just go on with the case then. All right, Maddie, if you could just drive that. Okay, get to the case, please. Okay, so this is a patient I saw almost 20 years ago. He, as you can see, is an 11-year-old male who fell overseas, had this Salter-II fracture, which interestingly was treated in a cast without a lot of reduction. And he presented to us 2 weeks later. Next, please. We tried to pull the fragments out with a little traction, didn't work. He ended up with an open reduction internal fixation with smooth K-wires, with, satisfactory alignment and early healing. And you can keep looking at the time here. So it was December 2006, which was, a month later from injury. And so 2 months following that, looks like it's healed in good alignment. Keep coming. Next. Okay, so now he is several months, about 6 months later, and he's got a valgus deformity. We got an MR, which based on radiology reading, did not show a physeal arrest. And there was some irregularity, but it was hard to know whether there was a discrete sort of spot weld type of physeal arrest. So let's see if there's a polling question next. Yeah. So what would be your next step? So everybody, including panelists, can answer, I guess. Would you observe? Would you do a physeal bar excision, although you don't see a discrete bar? But there is some irregularity. Sorry. Would you do a standalone medial distal femoral hemiepiphyseolysis? Would you complete the epiphyseolysis of the distal femur? Would you do an osteotomy with acute correction? Would you do an osteotomy with a gradual correction? Would you do one of those osteotomies with completion of the physeal bar? Or, I guess a different option. There's just so many permutation combinations that in some ways this is an unfair question, but also is a real life situation because we've got so many options in a growing child with a partial post-traumatic physeal bar, which is not that discrete on an MR. And I purposely chose this case to just show that, how people can also get misled, including myself. Okay, so here we've got, Maddie, they can see the results?
Yes.
Okay, awesome. So a third of you thought a medial distal femoral hemiepiphyseodesis would be the option, followed by a physeal bar excision. So that actually makes me feel good. Let's go to the next slide. So I got to stop sharing. Okay. Next, please. Okay, so I did nothing to the physeal irregularity because there wasn't a resectable bar, and I just put in a medial plate, and then you could see the patient gets lost for 2.5 years and comes in with not a lot of correction, although a little bit of splaying of the screws for the guided growth plate. And you can go to the next slide. So, this was a bunch of years ago. We did do an external fixation, lengthening, angular correction to restore his length and alignment. And, in some ways, this would be considered a good result if you look at it just in the frontal plane. But, what I didn't pick up early on in the treatment was that he had a sublux patella related to his valgus. And by the time I really tuned into that, he had developed pretty symptomatic patellofemoral arthritis from lateral subluxation / dislocation of the lateral femoral condyle. So that was a bummer. Go to the next slide. So I think, and I'm not going to push this as the technique, but I think there is a lot of talk these days, and we're doing some work with, a radiologist, Diego Jaramillo, down in Hospital for Special Surgery, where they've got these new sort of software for MRI to look at the physeal biology, not just look at it anatomically, but physiologically. So maybe, is there a next slide? Okay, so in summary, I think we've all heard a lot from, great talks and cases. You got to address problems before they become irreversible. Assess whether the growth plate is actually sick or dead. It's not over till it's over, right? We've heard that a bunch of times. And please don't make decisions based on, uniplanar imaging alone. So I'm going to stop there, and let's see if all the panelists can switch on their cameras, and, we'll just open it up. And Maddie, if you could just go back to the X-rays initially, and where we asked the poll question. And really, I'll just open it up to anybody in terms of maybe, can we put up that poll question about options? Yeah, there you go. So anybody can, start. Do you think I certainly didn't do the right operation by putting a guided growth plate when the physis didn't look, dead. But I got fooled because physiologically it was really dead in that portion. It wasn't functional. So do people have tricks on how to assess that besides, fancy MRI imaging, which is not available to a lot of us in parts of the globe? How do you assess a sick physis to know what's going to be resectable or not? Or I guess a broader question is, what are the indications for physeal bar resection? Yeah, anybody can talk. Chris, are you ready, Christoph?
Yeah, maybe. For me, I always find it easier to see it in the CT scans, especially small bars. Or I think it's important to talk to the radiologist that they know what you want to see. So just sending the patient to like a knee CT might not get you the information you need. So I usually tell other radiologists I need like just the physis or just like this proximal part, like if it's a tibia or if it's a femur, like just the area of the physis, but really, really thin slices. And then you can get this kind of 3D mapping, and then you can really see the bar, the location of the bar, and also the size of the bar quite well. So I think that would be, so I would think I would have chosen 7 and ON for ECT.
Yeah, but like in this situation, there wasn't really a discrete bony bar. What if it's a fibrous bar, etc.? Like, so when would you do a CT versus an MR versus both? And
I mean, both is ideal, but
both is ideal. Yeah. Okay. And I see Rick's hand was up. Rick Gardner. Rick, what do you think?
Yeah, thank you. No, Sanjeev, it's a great case, and I think many of us would have done just the same as you. I just wonder the other aspect is just combining the medial distal femoral epiphyseolysis with an osteotomy. It's a sick physis. I agree. It's not one. I think I would have done an epiphyseolysis because it was patent, but it's a sick physis, and if you can actually offload that to some degree, then maybe that would give it a chance. So to get mechanically it straight, plus the hemipiphyseolysis, it would stop it from getting worse, and maybe it would give it a chance to recover. But I think I would have done just the same as you did in this case. It's only with hindsight.
Yeah, but again, I lost this kid for like 3 years, and one is to just like hound them, come back, send them letters, praise them. I think that's another lesson learned, which we all get burnt. And then finally, don't just look at the frontal plane and kind of think of the patellofemoral joint too. Tharul, you got your hand up. Please.
Yeah. So, whatever imaging you do, CT, MR or diffusion tensor, there is no clear answer to know what is the potential of that physis to grow. And many times just putting a guided growth will give you the answers. See, Sanjeev, in case you put that guided growth plate and it corrected, your presentation would be different today.
Totally.
And I'm sure none of us would know. So when there is no bar, you can't excise it. But I think you did the right thing. You give that physis a chance.
Yeah.
So always give physis a chance. That's
right. But again, his patella was probably sublux for multiple months, in between. I could have picked that up and maybe had my sports guy done an MPFL reconstruction, have you, what? Okay, Miguel.
One more point I want to sort of emphasize here, which was not discussed, is that many times you get a successful result of bar excision. But only, when that child becomes older and grows, in the second growth part, you will realize that bar which was successfully excised and give you a good result. Sometimes that physis run out of breath, and you will get recurrent deformities and shortening closer to maturity. So you must follow these children again.
Yeah, or longer. Yeah, exactly. Good point. Okay, Miguel.
Yes, and the last slide you put there, you were talking about maybe there was a lack of image at the beginning. So I think you could touch the patella. I'm sure that this luxation of the patella, you could guess that something was wrong there from the beginning. So I'm worried in these days that everybody is talking about image. But I think the good clinical evaluation, you should feel the patella luxated. Yeah. So in the beginning, if you feel that the patella is luxated or is not working well, so the treatment should be different. And it's more important the patella luxated than the valgus. The valgus is only, and it's easy to fix, but the patella luxated is a big trouble that we have now. So I'm worried about that because I think the clinical evaluation wasn't
right. Totally. No, right. I so totally get it. And to your point, but I feel like the valgus did drive the patella to sublux, correct? So perhaps, in hindsight, completing the epiphyseolysis, doing an acute or gradual correction of the valgus would have been the smarter thing, at least in hindsight, right? Sandeep, what do you think?
Yeah, Sanjeev, interesting case. So I just wanted to bring a different perspective to the growth arrest that actually happened. If you saw the patellofemoral imaging, there was a lot of trochlear dysplasia. Mm-hmm. So I wonder if the growth arrest had a 3-dimensional effect on underdevelopment of the groove itself, which contributed to the patellar subluxation. And it was not only the valgus. Yeah. So we always think in only two planes when we are looking at sagittal or the torsional, as well as what happens to actual morphology of the intra-articular surfaces. Sometimes there is a tenting and the tibial slopes actually go downward. So the de-tethering always has a very good effect on restoring articular congruency, I would say. It offers the joint a better scope to grow a little better. And combined with mechanical axis correction, I think that is what I wanted to get the point across. And lower femur can be funny because there's a third joint involved, the patellofemoral, like you showed ultimately.
Yeah, totally. And I think, was it Chris Yopes had his hand up? Chris, did you want to say something?
I was just going to ask, is it okay if we ask a question to one of the previous speakers? I know we're almost out of time. So.
Absolutely. We got 4 to 5 minutes. Yep.
Because Dr. Eidelman was showing some images of his epiphyseolysis technique. I was wondering if he could elaborate on how he uses, it looks like a cannulated drill over a guide wire.
Mark, are you there? Is Mark Eidelman there? Okay. Well, that does bring up a good point. This one incision versus two incision. Is that what you're, implying, Chris? That do you? Because I know you said you'd like to go medial lateral, especially in the femur, and I agree. I do the same. And then Mark showed a picture where he was going front to back and side to side, but I have a feeling he was just going he wasn't switching C-arms or sides to do the drill. Was that the gist of your question too, Chris?
Yeah, well, I mean, I've seen him speak on this before, but I know he sort of promotes this technique where he shoots a guide wire through the center of the physis, and then he just puts a cannulated reamer over it and just cores out a simple core. And I'm just curious how successful that's been for him and what size reamer he uses and those kind of technical tips. So.
What do you do?
I do the halfway across both sides with a small drill, and then I use curettes to scrape out as much as I can.
Yeah, that's kind of what I do too. I actually, for the most part, I use the 6573 cannulated screw set. It's got these bigger drill bits, and then I fan it just like you would do for a drill hole osteotomy on both sides. And I just make sure I swing to a lateral, and I've covered most of the front to back. But let's see, other people do differently. Christoph, what do you do?
Yeah, I do a little bit of technique as Mark was showing. So I do drill a K-wire like in the middle of the physis, make sure in the lateral view that it's exactly in the middle. And then I use cannulated drills that you use for cruciate ligament reconstruction. And I usually go up to 12 millimeters, which is a pretty big hole. And I fan very carefully, and then I scrape it out a little bit with like a shock spoon. But that's I only come from one side, and I think if you need to be careful, you need to be very careful that you really get the edge of the opposite cortex. But I didn't have any bad experience doing this, and it's a very simple technique.
Yeah, no, I think whatever works in anybody's hand. The other thing I sort of tell the residents a lot is the femur is a smiley face, the tibia is a sad face. So you got to look at the physis and, start where you can. And, if you go back to the Femister era, they really were just doing it peripherally and then, moving the graft around. One other question that comes up is, what's the post-op management after epiphyseolysis in terms of weight-bearing restriction? Do you let them fully weight-bear? Is there any activity restriction if you're doing an uninstrumented, epiphyseolysis, let's say with a large size drill bit? What do you do, Christoph?
And we have a routine of using partial weight bearing for 4 weeks, which, we've been doing this technique for more than 20 years. And in these 20 years, I've never seen a fracture. And I'm very sure we had patients who were not using the crutches. So, it's more like a protecting ourselves, maybe more than the patient, I'm not sure. So I think that the concern of like epiphyseolysis is maybe not that big, but you never know.
Awesome. Oh, I think I overshot a little bit. I'm sorry. How would people feel that you just take a break, as we go on? And I think we could, just for the sake of time, you could just move on to the next phase, and we can put in our break slides, after the next break. So I'm sorry, I went a little over. It was a great discussion. So let's just move on to the malunion section, guys.